Hi, everybody. Welcome to our pediatric cardiology session. I am Anjali Malkhani. I'm a pediatric gastroenterologist. For those of you who don't know me, I'm filling in for Dr. Toole today. It gives me great pleasure to introduce our speaker, Dr. Rajni Anna. Her topic today is recognition of congenital heart disease. Before we get started, I think we all should introduce ourselves. And how many are we logged in today? So 5 logged in today. 8? Okay, 8 of us. Just make a note that all of you have been muted. So if you have a question or a comment, please click on your microphone icon so that everyone can hear you. How do we do this? Do we get started to introduce?
Hi, it's Dawn Toole. I'm with ETSU Pediatrics.
It's Diana Hyman, and I have Allison Schaefer here. We're waiting for the residents to show up, but we're from Johnson City Family Medicine.
Welcome. Oh, we can't hear.
I'm a retired pediatrician.
Thank you.
Just here to listen to
Phoebe
Dawn.
Wallace. Yeah, go ahead. Phoebe Wallace, Cherokee Health Systems. We should have some more joining, hopefully, as soon as they finish seeing patients.
Oh, thank you. Thanks.
Hi, this is SOFA Pediatrics. We got Johnson City Peds and First Choice Peds.
Thanks.
Oh, we didn't hear you.
You might not have the mic.
Oh. Okay, hi, but we can't hear you. Just a reminder, everybody to call in for credit. We need to call 423-200-3259. Event ID is 283064. There you go. There's the numbers on the screen. Before we get started, I'd like to introduce Dr. Alex Bowley. She's our pediatric resident who's going to be presenting the cases that Dr. Rajni is going to discuss later on. Okay, can we get started?
Okay, for our first case, we have AM. She is a 22-year-old G1P0 presenting to the cardiology clinic for fetal echo. On previous ultrasounds done at her OB, she was found to have an irregular fetal heart rate. Mom has no significant past medical history or family history. And on fetal ultrasound, she was found to have complete heart block with structurally normal heart and no fetal hydrops. Given the finding on echo, the mom was tested for lupus antibodies and was found to be strongly positive. So he was later delivered via C-section and had APGARs of 6 and 8. He initially required a little bit of low-by oxygen in the delivery room, but transferred to the NICU on room air. His initial heart rate was 58. And then here is the EKG tracing that we got after delivery.
These are the P waves, and the QRSs are right here. So there's no connection between the atria and the ventricles. This is an EKG of a complete heart block.
So, like Dr. Anand said, EKG
Next one. This is the one looking. Yeah. This is one of the pacemakers. You want to go to the previous one? Brian, can you go back to the previous slide?
So the EKG found to have third-degree heart block with a ventricular rate of 58 and a QRS axis of 70 degrees. He remained stable for the first couple of days, but then the heart rate further decreased and he had increased tachypnea. So on day of life 3, it was decided to have a pacemaker placed with a rate set at 80. And then you can see his EKG now with the pacemaker in place.
So I want to thank Alex for coming in to present this case. She's working in the ER at nights, but she's bright and awake to present these cases. We picked these cases because of a couple different reasons. One of the reasons I picked this case was to just bring awareness that we are detecting more and more complex heart babies as a fetus, not just complex structural heart babies, but also fetuses with arrhythmias, either fast heart rate or slow heart rate. And the second thing that I wanted to sort of bring about with this case is there's multitude of factors that are associated with increasing risk of heart defects in a fetus. And this I'm sort of going to divide it into 3 groups, and we're going to talk about it more. So the risk factors can be familial risk factors, can be fetal risk factors, or maternal risk factors. And this case sort of brings about both maternal and fetal risk factors. The third thing that I wanted to sort of bring about this case was to try and get the input and involvement of the primary care physicians to identify these families who are at high risk for structural heart disease. So again, with this case, it is one of a fascinating case. Maybe I brought this in because I made the diagnosis of maternal lupus, or we put the pacemaker here locally at our med center, and he's one of my cutest little kids that comes and says hello to me and says my name very nicely too. But besides that, this maternal lupus, the crossing of the IgG antibodies around the second trimester causes destruction of the AV node. So these kids end up with complete heart block. So mom who has lupus has a risk of having a baby with heart block 5%. So that's a pretty significant increase. And if this mom was to have a second baby, her risk is up to 11%. So this is where I need the physicians, primary care physicians, to be aware of the recurrence risk can be quite high, because when I'm talking to parents with complex heart disease or when they're in so much trauma, they're not ready to listen to my recurrence risk in future pregnancies, because they're more concerned about the current pregnancy and what's going on. So there are a lot of families who are at high risk for structural cardiac defects, and we're going to talk a little bit more about it. And we have one more case to present.
Case 2, HH is a 3-month-old female presenting with cough, congestion, and increased work of breathing and fussiness for the last 3 days. Patient was born via an uneventful pregnancy at home, and mother did not seek any medical attention. Following delivery, she had limited pediatric visits. So this was in the ED, and she was found to be RSV positive, and she had evidence of heart failure with hepatomegaly. An echo was performed, and it showed complete endocardial cushion defect. On physical exam, evidence of phenotypic features of Down syndrome were seen, and she did require a repair at 8 months of age and subsequently had heart block requiring pacemaker placement.
Yeah. So again, I picked this case sort of to bring out a couple different reasons that heart defects can present itself at very different age groups. And also to sort of emphasize the changes that are happening in the physiology of the cardiovascular system. Cardiovascular physiology is the most interesting thing in the first few weeks of life that changes so rapidly from a fetal stage to a transitional stage to a newborn stage, and we're going to talk a little bit more about it. And again, the presentation of cardiac defects can be at different ages. And again, this baby, yes, was born at home. Probably nobody heard the heart murmur because this baby is born with a huge big hole in the center part of the heart that causes no loud murmurs. Again, my point is a lot of complex heart defects do not cause loud murmurs that we like to hear. So again, this kid was doing fine. Nobody picked up any heart defects, but the kid ended up with an RSV infection. So the kid was going along with minimal congestive heart failure. And once the RSV infection came on, this kid had more frank congestive heart failure that brought us to our attention. So what I'm trying to get to here is chromosomal anomalies have a very high risk of congenital heart disease. So this baby should have been picked up as a fetus, or even at birth. If the baby had Down's features, this kid needs a fetal echo Doppler study. So Brian, you can put my slides on. So what some of the questions that I get from parents are always very interesting, and during my talk, I'll sort of address a couple of them. So a lot of mothers come and say, why didn't the OB pick this heart defect in the OB ultrasound? So that's one thing. So I need to explain to them, and we'll go over that. And another thing that I always get is, why didn't my pediatrician or a primary care physician pick up this heart defect on the newborn physical? So that's another interesting thing that I always have to explain to them, that your pediatrician did not miss it, but it was just not found at that point because of the physiology that's going on in a newborn baby. And a couple other questions are also interesting. So mothers always come and say, what did I do wrong to have a baby with a heart defect? Or the other interesting thing is, oh, it's nothing in my family. It's always on the other side of the family that has all the problems. So I'm trying to explain to them it's nobody's fault, or it's not yours or mine that it happens. And it's a miracle that most of us have a normal heart. So with that, I'm going to go to the to my slides. I have a lot of slides, but I won't go through all of them. So basically what my plan at this point is to sort of discuss the different methods of detecting cardiac defects. So I'm going to go from the earliest, that is the prenatal stages, second trimester prenatal OB and fetal ultrasounds, and then I'm going to come to our postnatal pulse ox test, which we've been doing in Tennessee since 2011. And then the postnatal history and physical exam, which is the age-old way that we detect our cardiac defects with the help of different things, EKG, echo. I didn't put an echo. That's like a lot of neonatologists say, you come in with your magic wand and just sort of put it on the chest and tell us what our baby has. But yes, echo Doppler studies have done a lot of good for us. And couple other things as we go along. I'm going to talk a little bit about the physiology, the anatomy, and couple EKGs and chest x-rays if we have the time. So I'm going to sort of start from the beginning, and it's the embryology of the heart. And basically what I want to show in this is the heartbeat starts at 4 weeks after conception. That is, even before the heart gets this normal 4-chamber view with the great arteries and all that, the heart is already beating, and it's helping the rapidly developing fetus. When you look at it, the heart starts from a single tube. It has to fold, it has to divide, it has to twist to give us this normal 4-chambered heart with 2 great arteries that are normally related. And when you think of it, all this is complete by 8 weeks post-conception. So a lot of mothers even are not aware that they are pregnant by the time the heart is already formed. So what I'm trying to get to is, if at this stage, the rapidly growing fetus is exposed to something that is not normal, that's when the heart defect forms. And from 8 weeks onwards, this heart defect persists unless we intervene it with a fetal intervention, open up an artery or open up a valve. This defect continues to be there till the baby is born. So what is the earliest stage that we can detect heart defect? That's usually in the 2nd trimester. Press the wrong one. Okay, this is the next one. So what I wanted to show you was, typically by around 17 to 19 weeks, we can image the heart. You can see the 4 chambers of the heart, you can see the aorta, you can see the pulmonary arteries. Typically, we can see the structure of the heart, the function of the heart, and the rhythm of the heart. And so the earliest detection that is possible for us is in the 2nd trimester. okay, second trimester. So that is, every pregnant woman gets an anatomy survey. That's the routine thing that the OB people do at the second trimester. And one of their check marks that they have to do is, do they see a 4-chamber view of the heart? They look at the lungs, the kidneys, the bladder, but one of the important things is the 4-chamber view of the heart. If they find a 4-chamber view of the heart, you have ruled out 40 to 60% of complex heart disease. Not all, just 40 to 60%. Again, you can sort of imagine transposition of the great arteries has a normal 4-chamber view. So if you add in the outflow tracts, the detection rate goes up a little bit more, okay? So once again, OB ultrasound is one of the first ways that we can detect complex heart disease if they have an abnormal 4-chamber view, and that is one of the ways that we detect it. So what is the next way? The next is sort of we come into our fetal echocardiogram. So like I was mentioning earlier, there are a lot of factors that that increases the risk of having a baby with heart defect. So let's go with some of them, and I have a lot more, and we have nice guidelines that we go by so we can tell them exactly what your risk of having a baby with heart defect is. So let's look at, I like to group them again. So let's look at maternal risk factors. So when would it be that I would be doing a fetal echo on a mother with any problems? This is the biggest thing: diabetes, pre-gestational diabetes, poorly controlled diabetes. The risk of this mom having a baby with heart defect is like 5 to 10%. And the most common heart defect is transposition of the great arteries, or the VSD. Again, exposure to drugs. We have all kinds of drugs, SSRIs and NSAIDs and vitamin A, lot of different drugs. And again, we have a lot of different percentages for it, but I won't go into too many things. Retinoic acid, there's a 20% risk of having a baby with heart defect, and these are conotruncal lesions. Lupus, we went over it. So there's a big risk of maternal lupus with complete heart block and structural heart defects. Rubella is another one. Infection in the first trimester can cause heart defects, and usually we think of it as a peripheral pulmonary artery stenosis. So when you have a mother with these high risks, these are the ones that need to come to us for a fetal echo Doppler study, again around 18 to 19 weeks gestation. What are the fetal concerns? So if the OB thinks that there's something wrong with the heart, or even extra cardiac problems, say for Turner's, you have increased nuchal translucency, we look for the heart. Chromosomal anomalies, the trisomies, and we already talked about Downs. There's a 50% risk of this baby having a endocardial cushion defect, trisomy 13, 18, 90%. So these kids are picked up as a fetus with complex heart disease. So again, maternal risk factors, fetal risk factors. What about familial risk factors? What if there is an autosomal dominant lesion in the family? Like we just saw last week, a family with tuberous sclerosis, and the fetus had multiple rhabdomyomas. These are multiple tumors in the heart. So familial risk factors. If mother herself has heart defects, say for example aortic stenosis, her fetus has a 16% risk of having a heart problem. So there's a lot of different risk factors that we can sort of try and see if we can pick these babies as a fetus. So again, like I said, the earliest that we can pick these fetuses are around 18 to 19 weeks. I know this sort of blocks it here. So what are the reasons why we miss it in an OB ultrasound or a fetal ultrasound? Again, remember, like a lot of mothers come and say, why didn't the OB pick it up? Because the heart that we are looking at is the size of a quarter. It is such a small heart. And this is the heart that we are looking at through the mother, through the amniotic fluid, through the baby's ribs to get to this heart, to look at the 4 chambers, the 4 heart valves, and the 2 great arteries. So what are our limitations? If the mom is huge, and most of our diabetic mothers are overweight, obese, and have big abdominal fat, and it's not possible for us to get good pictures. If they have previous scars on their abdomen, not possible for us to get good pictures. Okay. What are our limitations with regards to the fetus? If there is too much fluid, amniotic fluid, we won't be able to image the heart very well. If the baby is not in a good position, it doesn't matter how much time we spend. And again, it's so hard to get that kid in the right position to look at the heart. And what are other limitations? These are all the reasons why we miss detecting heart defects in a fetus. Again, our experience, and again, I should put here the patience, because if we are not patient, if we don't spend time with these fetuses, it's hard to get these pictures. And I'm so happy to work with my echo technicians, both in the office and the hospital, have so much patience. It's like they spend hours together trying to chase this little fetus that's floating away happily, and we have to find this little heart to look at the heart defects. So this is a case that I just wanted to bring out to say why we missed this kid. There was this kid, again, a lot of maternal risk factors. This kid was missed by both fetal and OB, but we knew we had to check this kid out soon after the baby was born. So maternal risk factors: mom was advanced maternal age. She had pre-gestational type 2 diabetes. She had hypertension. She came for prenatal care after 12 weeks. So by then the heart is already formed. So there is nothing that we can counsel her. I wonder what the glucose control was at that point, hemoglobin A1C. So those are all the things that I'm trying to get. We need to get these mothers before pregnancy, early pregnancy, to prevent these complications. And the fetus was also very small. We couldn't really get a good picture of the heart. Yes, the OB and the fetal ultrasound, we saw 4 chambers. We also saw a moderate size VSD. So again, when I say moderate size VSD, the baby's heart is like a size of a quarter, and my VSD is 2-3 millimeters, and that is, yes, a moderate size VSD. We couldn't see the outflow tracts, and we couldn't see the outflow tracts. We tried very hard. The baby was born at 37 weeks gestation. The baby weighed 1.6 kilos, became cyanotic within a few hours. We did the echo. The baby has transposition. Again, infant of a diabetic mother, this is the most common heart defect, and these are the mothers who need to be screened. And I love the KUB. I mean, you really, when you have a complex heart baby, you want to make sure the liver's on the right side, the stomach bubbles on the left, and look at the heart. This is sort of the typical picture for transposition, egg on the side held by a string is what we call it. So there are reasons why we miss picking up even complex heart defects as a fetus. So my sort of take-home message with this part of detection is it's very important for pre-pregnancy counseling in high-risk mothers and high-risk families because of the recurrence risk. We need to keep in mind that OB and fetal ultrasounds are not ideal screening tests, but they do help, especially for any kind of a fetal intervention, monitoring, planning of the delivery of such fetuses at tertiary care centers. This is very important because if we have a fetus with complex heart disease, we get the mothers to deliver at tertiary care centers where surgical intervention is available. So the mother's not here and the baby is transferred over to a different place. So once again, sort of keep in mind the risk factors that in the families, in the previous siblings that you may have, that puts this mom at a high risk of having another baby with heart defect. So again, sort of help with from the pediatricians to pick up these babies at as early a stage as possible for a better outcome. So that was prenatal sort of picking up of heart defects. So let's go now to the postnatal screening. And again, as we were talking about earlier, this postnatal CCHD or pulse ox test has been a standard of care in Tennessee and a lot of places, pretty much all states in the US. So what is our goal? Why are we doing this pulse ox on babies? So our goal is to identify newborn babies who are at high risk for hypoxia because of a closing PDA. Okay, again, remember, we're going to talk a lot about these fetal channels and when do they close, why do they close, and how do these kids present to us. So any congenital heart defects that needs PDA for the baby to survive. So if the PDA is closing up, these are typically the 7 lesions that we talk about that can be picked up by this pulse ox screening. Okay. Once again, we always say none of these screening tests replace the complete history and physical after the baby is born, but this is another test that we have been doing that helps us to identify some of these complex heart defects. Again, you know pretty much all this, so I won't go through the normal protocol, but typically done in term babies. Usually kids are over 34 weeks gestation at 24 hours. Once again, why 24 hours? Because we are hoping that the PDA would have closed by then, but the PDA may not have closed. So there are a lot of kids that we miss even with this screening test. Okay, so, and the next couple slides tell you the protocol that we use and when is it positive, when is it negative, what needs to be done if a baby fails a pulse ox or a CCHD test. So if a baby has a positive screen, this kid requires a comprehensive evaluation for the causes of hypoxemia. Again, think of it, a hypoxemia and cyanosis is just not hard. There are multiple causes for cyanosis, but if you have a positive CCHD test, this kid needs an echo and a pediatric cardiology consult. So with this screening test, once again, sort of my take-home message is it is not ideal. It is not 100% sensitive or specific, but this is something, a standard of care that we do right now, especially in hospitals where pediatric cardiology services are available. We can very easily come and do an echo Doppler study on these babies. These babies don't have to be transferred to another facility, so we can easily rule out heart defects. Again, think of the other causes for cyanosis. Okay, it's not just the heart, but we always start with the heart. Also, again, a lot of our complex heart defects may not be cyanotic. Okay, that's another big thing that we need to remember. Not all our heart babies are significantly cyanotic. Once again, I keep coming back to this, saying that no screening test can replace your history and physical. So it is very important. Again, the cardiovascular system is going through rapid changes in the first few weeks, so keep repeating your cardiovascular examination. So what I'm going to next in a few more slides that I have is to sort of talk about postnatal detection and why it's a challenge for us to pick up these babies even postnatally at times. So we're going to talk a little bit about incidence etiology, and I do want to get into physiology because that's what makes sense as to why these kids present to us at different times in their life. Clinical presentation, and if we have time, I'll show you a few EKGs. So what's our incidence of heart defects? You know, heart defect is the most common birth defect, except we still don't have an ideal screening test for it. We have all kinds of screening tests for PKUs and thyroids and all that, which is 1 in 250,000 or something like that, but this is 1%. So one baby out of every 100 babies born have heart defects. That's about 35 to 40 infants in the US that are born with heart defects, and about 25% of them need heart surgery or intervention in the first year of life. So once again, most common heart defect, we have no good screening test, and etiology. This is always interesting. So what caused heart defect? Did it come from my side of the family or the other side of the family? Basically, just to say we are pretty sophisticated, we say multifactorial. Basically, we don't know what's causing heart defects, or we are sort of dumb at this point not to know what causes heart defect. But we do know, like we talked about, there are some genetic syndromes that have a very high incidence of heart defects, if the mother, maternal diseases, and if the fetus is exposed to different drugs. So keep all this in mind when we are trying to sort of pick up these babies. So I told you I would go a little bit into a fetal physiology because this is interesting for us to know why these babies present to us. And again, look at all the fetal channels here. So these are all the fetal channels that help with your parallel circulation. And I always put here, never trust a neonate. Really don't trust a neonate. They may look nice and pink, but very few hours later, they may be very, very blue. So let's go over the physiology just a little bit. Fetus, this is a fetal heart. Fetus lives in a very hypoxic stage. The PaO2 is like 30 to 35%. The pulse ox is about 80%. PaO2 is 35 to 30 millimeters of mercury, sorry. Pulse ox is around 80%. So what happens in a fetus? The blood's coming back from the ductus venosus that has actually the most amount of oxygen. And that goes through the PFO into the left atrium LV and goes into the aorta to supply the fetus's brain and the myocardium. So if there was no PFO there was no blood going into the left side of the heart because the lungs are a solid organ. It's not used for any air exchange. It's the placenta that's being used. So if you have a premature closure of your PFO, the left side does not form. That's why we think hypoplastic left heart develops. And some people have gone into balloon this restrictive PFO in a fetus. High risk procedure, but it has been done, but not with very good success. So what happens? The rest of the blood, so a third of the blood goes this way to supply the fetus's brain. 2/3 of the blood is pumped by the RV to the main pulmonary artery through the PDA into the aorta. So once again, PFO, PDA is needed, right? With these structures, even if you have half the heart, it doesn't matter. The fetus is growing very, very well. So what happens when this baby is born? The first breath, the cry, the mechanical expansion of the lungs are no more a solid organ, okay? So the lungs get filled up with oxygen. This high oxygen tension closes up your PDA. The placenta is gone, so the systemic vascular resistance falls. And these are all the physiological changes that happen that we need to be aware of as to why these kids present to us with either cyanosis or cardiovascular collapse. So cardiovascular system is the most important organ in a new baby that's changing very rapidly in the first few days of life. So again, fetal channels, keep this in mind. And whenever I'm doing fetal echoes, I always say, these channels are still open. There are still some heart defects that we cannot really rule out, even with a good, adequate fetal echo pictures. Once again, don't trust this neonate because they may look nice and rosy, but the next minute they are blue. So let's sort of look at two heart defects and just both ends of the spectrum. The pulmonary atresia is your hypoplastic right heart, and the hypoplastic left heart is the other end of the spectrum. So what happens in this kind of a heart defect? The right ventricle is small. There is no connection from the RV to the PA. Pulmonary atresia, there's no pulmonary valve. This fetus had no problem because the PDA was open and the PDA was supplying some blood to the fetus's lung. So when this baby was born, the PDA closes up. If the PDA closes up, there is no blood going into the lungs to pick up the oxygen. So this is a baby that's going to present to you within the first few days of life with significant cyanosis, okay? First few days of life because the PDA closes up. So if we pick these babies as a fetus, we know we are there. We start prostaglandins and try to stabilize the baby to surgical correction. Okay, so this is a baby with intense cyanosis. Let's come to the other side of the heart. This is the left heart, hypoplastic left heart syndrome. So again, it doesn't matter in a fetus, the right ventricle is doing all the work. Even though your major pumping chamber is left, it's not there, it doesn't matter. The fetuses grow very well. Usually the hypoplastic left heart syndrome patients are usually males. They are usually 8 and 9 pounds, healthy looking, with 10 fingers and 10 toes. And it's hard for me to explain to the new parents that the heart is so messed up, but all they're looking at is the outside of the baby. So anyway, so left-sided heart structures are all small. Again, there's aortic atresia. The aorta is really tiny. But in a fetus, the PDA was open, so the blood is going from the pulmonary artery into the PDA and coming retrograde or backwards to supply the coronary arteries. Okay, so to supply the coronary arteries. So once the PDA closes up, there is no systemic blood flow. There's no blood going into the body. So these are the kids that present to you with cardiovascular collapse, mottling and decreased perfusion, no pulses and decreased urine output. They are cyanotic, but not as intensely as the pulmonary atresia kids. So now we can sort of understand why these kids behave the way they do, and it is so ideal for us to pick these kids up in the fetal stages so we can sort of plan, manage before they get acidotic, cyanotic, before we go into surgical correction. So the next couple slides, I'm just going to talk about a couple different ways that our babies present to us. Again, I sort of explained to you the physiology and the embryology. So I like to group things to make it just easy in my mind. So 3 typical presentations how babies with heart defects come to our attention. Again, the first one, cyanosis, blue babies. We all talk about blue babies as heart babies. Cardiovascular collapse, and then a more gradual presentation, congestive heart failure and pulmonary edema, like the second case that we presented. So we all know our typical cyanotic heart lesions. Either there is no blood going into the lungs or there's too much mixture within the heart. Transposition, truncus, there's too much mixture. So these kids come to us with significant cyanosis in the first week of life. So these are our 5 T's, and some people put the tiny heart as hypoplastic left heart here too, but typically it's put in the cardiovascular collapse. Again, these babies come to us in the first couple weeks of life. So these are the ones that go home as long as the PDA is open, and then they crash and come back to us. This is the typical presentation of a kid with coarctation. As long as the PDA is open, we pretty much miss everything. The pulses are fine, the pulse ox test is good, and as the PDA closes up, and when does the PDA close up? It can take up to 2 weeks for the PDA to close up. So these are the kids that present to us in the 2nd, 3rd week of life. So the other group of how kids come to us, we talked about the gradual presentation. And again, remember one of the questions, why didn't the pediatrician pick up these heart defects when they did the newborn physical? If my baby was born with a big hole, why didn't we pick it up? Because we cannot pick it up because your RV pressure is high, there's no turbulence, there's no sound for us to hear, okay? So these are the ones that gradually, as the pulmonary vascular resistance is falling, the pulmonary blood flow is increasing, these are the kids that go into congestive heart failure, tachypnea, tachycardia, poor feeding, failure to thrive, and that's how we pick these kids up. And there are a lot of other ways that we pick up kids too, but I sort of don't want to confuse too much and go into too many more details. And let's see. So again, the big thing is cyanosis and hypoxemia. That's the big thing. We always talk about blue babies, blue babies. So yes, it is a very impressive sign of serious cardiac malformations, but this is not the diagnosis. This is an observation. So we need to know what is causing cyanosis. Again, think of a lot of different causes. I know I put cardiac and pulmonary pulmonary as the most important causes of cyanosis, but think of the other things, the infection, diaphragmatic hernia, neurological issues. But if there is a cyanotic heart baby, we would always want to rule out heart defects, because these are the ones that need surgical correction. These are the ones that need prostaglandins to be started so we can put the baby back into a fetal stage, open up the PDA and keep the baby stable. So there's a lot of different things that we have to look at that can cause more cyanosis or less cyanosis. I want to sort of show this a little bit. I know these days we have echo Doppler studies easily available to all of us, but this is a nice test that we still has a lot of use for us. So you have a cyanotic baby. So this cyanotic baby, is it CNS cause, is it sepsis, or is there a significant heart defect, or is there a significant pulmonary defect? So these are all our causes for cyanosis. When you do an ABG on them, they all have low PaO2. Okay, they all have low PaO2, so that didn't help us to differentiate as to what our baby has. So then you give, and again, this is ABG in the right radial artery. This is not just pulse ox. This is ABG, so you're looking at PaO2. Then you give 100% oxygen to all these babies. Again, be careful when you give 100% oxygen because you're closing up the PDA. So when you give the 100% oxygen, we call it as the hyperoxic test. Our babies with significant congenital cyanotic heart lesion, it doesn't matter how much oxygen you give, there is no blood going into the lungs. So your PaO2 is not going to go up. It's not this. These are our heart babies. If you have lungs, if there's VQ mismatch, you give a lot of oxygen, their PaO2 goes up. If right here, hypoventilation, so you give too much oxygen, the PaO2 goes up. This is a nice test that we still use in places where we don't have echo Doppler studies easily available for us to pick up heart babies. Because why? We want to start prostaglandins on these babies so we can get the PDA opened. Let's see. So my way of looking at heart defect is sort of, I again go with a systematic approach. Is this baby blue or is this baby not cyanotic? And then yes, exam is important. That helps you to narrow out your differential diagnosis. Chest x-ray, I know we talk about chest x-rays. There's nothing specific for a specific heart defect, but a lot of chest x-ray findings help us in narrowing our diagnosis. Is there increased blood flow, decreased blood flow? Is the heart big? So exam is needed, EKG is needed, x-ray, but yes, we confirm our diagnosis by echo Doppler study. So that is the best way to look at the structure, function, and again, I'm going to put all these up, but I'm not going to go into the details, but helps us how to come to a diagnosis. Even with just chest x-ray, you know what you're thinking about. And once again, this is, this chest x-ray, we can all know what the heart, there is no heart defect. The cyanosis is because of the diaphragmatic hernia there. And I have a lot of pretty x-ray pictures. I love this x-ray. I always call this as a wall-to-wall heart from one end to the other. And this is a typical x-ray for Epstein's anomaly. A lot of this is hyperinflation. This is total anomalous pulmonary venous return. Petrology. I mean, they may not look very specific to anything, but they do help. Chest x-rays do help. EKGs, I might stop after a couple more slides. EKGs, again, very helpful. Do an EKG if you have an axis up here in this quadrant. Again, it's pathognomonic for tricuspid atresia. So you don't have to get an echo. The baby is blue. You do an EKG. The QRS axis is sitting up in this quadrant. You have made the diagnosis of tricuspid atresia. If the QRS axis is in the left quadrant, you have made your diagnosis of pulmonary atresia. This is just by EKG. So yes, all these help us in detecting different heart defects. And again, this is one of my EKGs. This kid is about 20 some years old. So This was a prenatal diagnosis. This was pulmonary atresia. So this is a newborn EKG. Again, I tell all my residents and students, newborns have right ventricular dominance, right axis deviation. This new baby had left axis deviation and mostly left ventricular forces. That is totally abnormal for a new baby. So this is a baby with pulmonary atresia. And again, I can this is a typical EKG for tricuspid atresia. You can see the axis is positive here, it's negative here. So it's in the left superior quadrant. So you don't need anything else. This kid is not going to have any heart murmurs, but it's going to be blue and you have detected your heart defect already. So should I stop there? And again, I cannot stop without an echo picture. Echo Doppler studies pretty much helps us in knowing any type of complex heart defects. This is the typical picture of a hypoplastic left heart syndrome. The LV stops right there. It should have come all the way to the bottom of the heart. It never does. And you can see how thick the myocardium is, how echo bright it is. The aortic valve is small. So echo Doppler studies have really changed the way we detect heart defects and treat. A lot of these complex kids don't even need heart catheterization. They go straight to the OR with echo pictures. Yes, this is my heart catheterization numbers that we do, looking at the different pressures in the heart, and this is basically what tells us whether the blood is going to go from the right to the left or left to the right. So I can stop there if you have any questions, so that will give us a few minutes.
Does anybody have any questions? Well, I have a question. Is there, you mentioned in the fetal ultrasound, sometimes you can't pick up the defects, especially if there's many risk factors. Mm-hmm. Is there any use of doing an MR?
You know, for us to do an MR on a fetus, we have to anesthetize the fetus for it to be still. So because in fact the fetus floating around in the amniotic fluid helps us a lot, because sometimes if the baby is stuck in one position, we may not be able to see the heart, but as it's moving, we have to constantly reorient ourselves to how the baby is moving and rethink and okay, so is this right ventricle, left ventricle? It's not the position or the orientation, it's the anatomy. So no, MRI at this point, no, but fetal echo is pretty much the way we look at it.
That's amazing that at the size of a quarter.
Yes, it really it is, and we get so excited. I know. I mean, it's like our echo room is one of those. I always say it's like a confession room because it's dark and it's like we have the echo machine and we have the bed in there with the TV screen. And a lot of times I can't even see the mother or the significant other or the grandparents. It's my first grandbaby, so I need to see the baby. So my usual thing is at the end of my fetal echo, I turn the light on so we can see each other, and I always say, hope we don't meet again. So, so hopefully we, but the ones that we do pick up, they're very happy that we have picked up because they can plan and they can read, and we get them to go to Vanderbilt or UVA, see the surgeon, talk to the maternal fetal medicine, they know what's happening there. It's a much better way rather than a baby coming in cyanotic, acidotic. Fetal echoes are interesting, and it's nice for me because I'm not panicking. The fetus is happily floating away, and I can take my time to figure out what the heartbeat is.
I'd like to remind everyone to complete their online evaluation on the Project Echo page so you can get your CME credit too. Our next echo is December 5th, and Dr. Anand is going to focus on chest pain, syncope, and palpitations. And if you would please consider submitting a case or cases for that session. And the link for the submission form is on the project echo page. The next couple echoes after that are on January 23rd on lipid screening. Dr. Anand's going to go over the current recommendations on lipid screening. And then the one after that is in February, on February 20th on hypertension. I think that concludes today's session. If anybody has any further comments, questions, please feel free.
Thank you.